Hello, everybody. Welcome back to our brand new podcast. This is episode number 2 of Medics, Musings, and Mayhem. And I do have my special guest back again. Hello, Regan.
Hi, it's so good to be back.
So overall, we had some very positive feedback from the folks that listened. We already hit the 30s for listenership, so I think that's pretty great. I think we're making some progress, and there's clearly some interest in talking about all things protocols and all things EMS.
Yeah, that's not bad for our first round.
So before we chose our next topic, I wound up sending a poll out to our folks in my EMS service and gave them some choices, and the winning vote almost unanimously was all things cardiac. That's a lot.
Yeah, not a simple task.
I think the goal for the next couple of podcasts is we'll break it down step by step and try to keep these things under 30 to 45 minutes because I don't know about you, but I feel like all emergency medicine physicians have a little bit of ADD, and sitting for more than 30 to 45 minutes, you're going to basically lose your audience.
Oh yeah, I completely agree with that.
I think the best one to start with would probably be bradycardia, just because it's a little bit more straightforward. There aren't nearly as many caveats to it. Obviously, our tachyarrhythmias are a lot more messy, and I imagine that will require additional breakdown step by step. We'll use a similar approach to last time. We'll start with a little bit of a case. We'll talk about the pathophysiology of all things bradyarrhythmia. We'll talk about the medications that we use in our protocols. We'll talk about a little bit of evidence-based medicine, and we'll wrap it up by talking about the protocols and how we can use it in this particular scenario. Are you ready, Regan?
I am ready to go.
We're going to go back to you wearing your paramedic hat again. Pager goes off. You get a call about an elderly male that it needs assistance. Wife reports that he's not really acting like himself, complaining of a little bit of chest pain and is short of breath. That's a very, very broad differential initially, isn't it?
It is. My mind goes to at least like 3 things right off the bat, but you can't determine any of that until you get a little bit more info before you can move to that next step.
But it's always a good thing to have some form of differential in your head, start mentally preparing yourself for what this could be. I don't know about you, but the times where I'm in the ER and they bring in a coding patient, I really miss that prep time.
It's helpful to kind of get your head on straight before you run into these scenarios. Having some things in mind, you don't have to anchor onto any of them, but at least they're on your mind so that you could treat them if they're the ones that pop up.
Anchoring refers simply to having a diagnosis and clinging to it, even when there is evidence to the contrary to your current differential. So Regan, you arrive on scene, you get into the house, you find your patient. He does appear somewhat agitated, but he is willing to work with you. He's very cooperative for the most part. When you ask him who he is, he can tell you who he is. He is able to identify his wife, knows that he's at home, but he does tell you that he feels pretty weak. He gets dizzy and lightheaded when he stands up. And his wife does note that when she tried calling EMS, he tried to stand up and almost fell out of his chair. So what do you want to do first, Regan?
First, I'd want to ask a few questions while my partner is grabbing vital signs too. I could start figuring out things like, is it hypoglycemia, or am I moving towards a neuro situation, or is there a drug interaction involved? At this point, that differential is so long that I just need to grab a few more key things that might point me into one direction or the other.
I would say in this case, based on the scenario so far, we're dealing with an altered mental status / feeling generally unwell. And as we both know, that's an impossibly broad differential without additional context.
That's where that brief history and vital signs can start pointing you in one direction. That doesn't mean it won't turn later on.
Your partner has him hooked up to the monitor now. Vital signs that you see initially include a heart rate of 42. Blood pressure is currently 92/75. His O2 saturations are 98% on room air. He is afebrile. Your partner was on the ball and got his blood sugar obtained, and it is currently, we'll say, 75.
From those vital signs, we're a little hypotensive and very bradycardic. I mean, both of those are jumping out to me right away. Still good to see that oxygen saturation in there, but there are concerning things going on. So my mind is starting to turn about next steps that we would want to be taking.
And before you take those next steps, let's go over our algorithm that we've talked about last time. Let's go through our ABCDEs and see if there's anything else that might sway your differential further. Starting with airway, Regan, he is speaking in complete sentences. Breathing wise, there are no wheezes, there's no crackles, there's no rhonchi, and he doesn't appear to be in respiratory distress while he's sitting in his chair. Circulation, as you noted, he is bradycardic, but he does appear to be regular when you're feeling his pulse. Disability, GCS is roughly 15. As his wife noted, he's not quite himself. He seems a little bit confused, but as far as like basic questions, he answers them all correctly. And then without completely exposing him, you don't see any other signs of trauma or anything else that would make you more suspicious. Given all the information you have so far, Regan, where does your head go and what kind of things do you want to do first?
With being hypotensive and bradycardic, my mind's going more towards obviously a cardiac situation arising. So I would want a 12 lead to further get the picture of what's happening here, but also to continue asking those questions like what kind of meds are they taking? Do they have a pertinent medical history that we should know? Continuing to assess it, knowing that our GCS is 15, they are cooperating with us, and yes, they're bradycardic, but it's still regular. We have a little bit of time. Doesn't mean that we need to lollygag, but we can at least figure out what's going on here.
This is something where we want to have a little bit of cognitive awareness too, right? Like we want to make sure that we're really thinking through this. We want to have a good differential. And obviously we have the answer already because this is going to be a talk on bradycardia and bradycardic management. At the same time, I think a lot of us sometimes get caught in those headlights. The traditional system, especially from an EMS, emergency medicine perspective, is I need to fix that heart rate right now. When we think about that, the actions that we would typically think about would be atropine or getting our pacer going or something like that. But we need to be much more cognizant of what else could be within the differential. And that is the whole point of this podcast today. Which brings us to pathophysiology. And let me say, cardiac pathophysiology is complicated. I really didn't enjoy it when I was in my medical school years, and I only really came back around to it when I started dabbling in point of care ultrasound. And I have to say that now that I do echocardiograms on a fairly regular basis, I absolutely love talking about cardiac pathophysiology. When we think about pathophysiology when it comes to bradycardia, though, we can really keep it quite simple. We know that this is potentially a heart issue, and we also know that the heart is made up of the musculature, our cardiac muscle, but there's also a wiring system. Regan, why don't you talk a little bit about what exactly makes up this circuit that the heart has?
Yeah, so as you mentioned, a lot of us think of the heart as this muscle, but it's not just randomly contracting. It has to have some sort of control, and that's that cardiac circuit. Going from top down, we'll start up by the atria, so the top two chambers of the heart. There is a sinoatrial node that's in that right atria. That one is the natural pacemaker of the heart. That's the big dog that does all of the pacing for most healthy individuals. That is going to start the cardiac circuitry by creating this impulse that will travel through the atria and down towards the atrioventricular node. And that one's at the bottom of the atria, even though we hear that ventricular part in the name. The atrioventricular node will take that conduction and continue it on down through the ventricles. So from that, we already have that atrial contraction from that SA node, which moves to that AV node, or the atrioventricular node, which will then cause the contraction of those ventricles. That's how we get coordinated lub-dub of our heart, is from the electricity going through those circuits.
We can break this down even further, right? So we know that the SA node is our native pacemaker. This is not just referring to devices that we use to keep our patients alive. We have this thing built into our heart. So you get that signal fires from the SA node, it goes into your AV node, and then it gets broken down even further. And this is why it really matters, because we talk about different types of heart blocks that can cause bradycardia. Your AV node will go down into the bundle of His, which then goes into your bundle branches and then finishes in the Purkinje fibers. A lot of weird names, but it really gives us a better understanding of where this breakdown can occur. We will have a little bit of a figure that Regan expertly designed for you to look at in the show notes later. So there's our circuit, but there is some other things we need to think about when it comes to the heart itself. When we think about the circuitry does require a supply of some kind. So one of the things where we can see breakdown with our heart is when we lose that blood flow. So when Regan was talking about our native pacemaker, the SA node, that usually receives blood flow from two sources. And most people were going to get it from our right coronary artery, which is about 60% of our patients. The remaining 40% are going to get it from the left circumflex. So Regan, why does this matter to us? Like, why should we know about blood flow to our circuitry and to the heart itself?
Well, one thing that can go wrong with this is that blood flow becomes stopped or clotted or blocked off. And this is what happens in that myocardial infarction or a heart attack. Say we have a blockage in that right coronary artery, well, our SA node is not getting the proper blood flow, which can cause a dysarrhythmia because that circuit can't go in its normal conduction.
Right. So the sinoatrial node can get quite irritable and we can get some weird arrhythmias, like you said. This could be a tachyarrhythmia, this could be a bradyarrhythmia. I think one of the biggest things that anyone who's in medicine forgets about is that when we think about heart attacks, we think blood flow is cut off and the muscle starts to suffer. But there's more to it than that. Not only can the muscle suffer, but so can these conduction fibers, which can lead to two problems instead of one. Bottom line here is that disruption anywhere in this chain can potentially lead to a bradycardia of some kind. We've talked about the circuitry some, but now I'd like to focus a little bit more on what happens when that circuitry goes awry. The bottom line is that this is very complex. And talking about the entire differential for bradycardia could be multiple podcasts in itself. But this is just kind of going back to my point earlier that we don't want to just jump right to shocking the patient or pacing the patient or pushing atropine in. We have to think about what other possibilities could be involved. When we think about the bradycardic patient, there are two ways that bradycardias can arise. There can be what's called the intrinsic cause, which typically is going to involve the circuitry of the heart itself. Alternatively, there are extrinsic causes, which are what we consider the outside factors. Regan, when we think about the circuitry itself, what are some common things that you think about that can mess with the circuitry and that can lead to some bradycardias?
I think one answer could be just a congenital disease. There might be an anatomical difference that can cause that circuitry to not conduct properly, or there could be a blockage, like we talked about, where it's not getting that blood flow, causing that circuitry to go wrong. Another thing could be like infiltrate, so like growth within that, such as in a sarcoid patient. The list kind of continues to go on with it, but anything that's going to cause an issue from that conduction going from either node to node or through the bundle or in through the fibers, if that gets blocked off, there can be repercussions throughout the entire circuit.
Another way we can think about it and keeping it simple is that when we think about intrinsic causes, the circuitry itself gets affected in some way. So we've talked about infiltrates. The consistency of that wire has changed. Then when that signal goes through, it gets altered or it gets delayed because of that change in the composition. We could also have consequences of scar tissue from ischemia, but we could also even think about this in terms of really healthy people, right? When we think about athletes, they typically have a much slower resting heart rate. And that has to do with some of the changes that happen in their hearts to make them function at their highest competitive capacities. Let's talk a little bit about extrinsic factors. What are some of the classic ones that we think about, especially from the pre-hospital side?
Medications, toxins, chemicals, things like that can affect that cardiac circuit. There can also be neurologic dysfunction. If there's a vagal nerve stimulator, that can cause that decrease in heart rate. Or if there's a blockage of the vagal nerve too, then you're going to have a higher heart rate.
These are really good examples. I can also think of two really classic ones. One is from the context of NRP, which is our neonatal resuscitative program for physicians. What is the most common thing that harms infants, Regan?
Yeah, in neonates, the concern can be with decreased respiratory drive, or that loss of oxygen can cause their heart rate to decrease.
Right. Infants are very dependent on oxygen, and without that oxygen, the heart gets more irritable. And classically, this leads to progressively worsening bradycardia, which then leads to chest compressions and oxygen. But the main thing that reverses most bradycardia in infants is oxygen. Another classic example I can think of is when it comes to head trauma. If you've got a person that has a high impact head injury and has a sudden onset intracranial hemorrhage going on, you can get what's called a Cushing syndrome. With the Cushing syndrome, you get that increased compression, which then stimulates the vagus nerve, which leads to this profound bradycardia. But it's also a little bit paradoxical because the patient remains hypertensive. So that's another example of where patients can get bradycardic. The bottom line I want for people to take from this, though, is that our differential really should be broad when we start. And as we get more of a history, we can really start to hone in on how can we reverse the bradycardia that we're seeing. We've talked a little bit about the wiring. We've talked about the important aspects of blood flow. Maybe we should talk a little bit about the bradydysrhythmias themselves. I'm a very visual person, so I like to think about this from two perspectives. One, we could think about the location of dysfunction itself, or we could think about the location of the block. I imagine that some people will learn well from one way and some people will learn well from the other, so I'll just go ahead and unpack them both. When we think about location of dysfunction, we think about that solely with the anatomy we talked about already. So we've got issues with such as SA node dysfunction. We can have what's called escape pacemakers. We can have AV junctional problems. We can have idioventricular problems, or we could even talk about this from the context of the atria itself. When we think about SA node dysfunction, the things that we can typically think about is sinus bradycardia, which when you see that isn't necessarily a pathology. We can have sinus arrest, which is always a bad thing. We can have tachybrady syndromes, which are a little bit too complex for this talk, but we'll probably talk about it more in the tachyarrhythmias as well. But the bottom line is that the heart is very labile and the rates keep jumping back and forth, leading to some very labile blood pressures. Escape pacemakers. What is an escape pacemaker, Regan?
I think of this as a beat coming out of nowhere. You can have ventricular escape rhythms where the ventricles will contract out of sync. And you can see this on the ECGs as well.
Right. We also talked about native rhythms earlier, right? So when we think about the SA node, that is going to be a baseline rhythm that is much higher than if the ventricular is firing. And all along this chain, there are these little, for lack of a better word, nuclei that have a baseline rhythm. So if we lose the signal from the SA node, the next brain will take over, but it might go at a much slower rhythm. And so when the circuit is disrupted and we can't get that signal from this SA node, our heart naturally has this escape rhythm that comes into play, though it might be much slower. One that we don't typically think about is when we think about atrial fibrillation and atrial flutter. Remember that when we talk about these things, this is not exclusive to tachycardias only. We're talking about what is the atria doing and how is that impacting the heart. So you can still see atrial flutter or atrial fibrillation in a patient that is bradycardic. It's not super common, but it could still be seen on your rhythm strip. So don't be surprised if that pops up on an EKG when you're getting that printed off. We talked about aspects related to the location specifically of the dysfunction. Let's talk about locations of the block now. There are three main types that we think about. We think about just straight up blocked premature atrial contraction. We have SA blocks and we have AV blocks. A lot of this is pretty detail oriented, but I think when we think about it from a day-to-day basis, the ones that we're most interested in are AV blocks. So blocked premature atrial contractions, that just means that we've got something going on way upstream that's leading to problems. When we think about SA blocks, they can be complete or incomplete. So this just means that the SA node is either getting no signal through or it's getting a partial signal through, which can further confuse the circuitry. These are way less common. The ones that we talk about next are the AV blocks, which are things that we see on EKGs all the time. Regan, can you break down what are the AV blocks for starters?
Absolutely. So the AV blocks are the blocks that we hear when we are talking about first degree, second degree, third degree are usually the most common. And that second degree is actually broken down into two more, MSIII 1 and MSIII 2. But starting from the top and moving down, the first degree block is actually just this PR interval elongation, and that's about it with that one. So our SA node and our AV node are taking a longer time to talk to each other than normal.
When we think about first degree AV block, how long is our PR interval before we call it first degree block?
So our PR interval is normally 120 to 200 milliseconds, which is 3 to 5 of those small blocks. So as we get higher than that 200, that's where we have that PR interval elongation.
So anything greater than 200 is where we classify it as a classic first degree block. Are these generally life-threatening?
These ones generally are not. It's still something that you want to make note of, but if we see this in an asymptomatic patient, we don't need to be pushing the atropine or doing epi drips, things like that. It is not a life-threatening situation.
Moving on to second degree AV blocks. You mentioned already that we have a MSIII 1 type block, which is also known as Wenke block, and then we've got our MSIII 2 blocks. What are the differences between these two, and which one is dangerous?
So our MSIII 1, or our Wenke block, is when we have our PR intervals gradually elongating until we drop one of those heat waves. So we'll see that it can be a normal distance, slightly longer, slightly longer, slightly longer, and all of those are being conducted down into the ventricles until it gets so long where that P wave does not actually go through and we miss that QRS complex on our ECG. And then it just starts all over again. Whereas our MSIII 2, we have a constant PR interval, but just some of those P waves aren't being conducted through. So we'll see that every P wave will have a QRS after it, but we'll have a random assortment of that being blocked where it won't go down to the ventricles. And the MSIII type 2 is going to be a riskier one that can actually lead to a third degree block.
The way I think about this is typically that with the type 1, it's predictable, and we like predictable. Predictable is safe, we know what's coming, so I don't really think about that one as being as dangerous. whereas the type 2 block is unpredictable. And none of us like when we cannot predict when something might drop spontaneously. So that's the way I keep those two straight. There's a few additional nuances when we think about second degree blocks. Sometimes things get thrown around, such as a 2-to-1 AV block. This is simply referring to the idea that there are 2 P waves for every QRS. Compare that to what we call the high grade second degree AV blocks. This just means that there are multiple P waves before a QRS, but there's always a ratio. So there could be a 3-to-1, 4-to-1, 5-to-1. The list could go on and on. But the bottom line is the more P waves that you have before a QRS, the longer the delay and the more bradycardic the patient is. That leaves us with third degree block. What does that look like, Regan?
This one is where our SA node and our AV node are no longer talking to each other. It's a complete block between the two. So I actually think of this one as there's 2 different heart rates going on. Your sinoatrial node is beating at its normal pace, but it's not talking to the AV node. So that one starts beating at its own pace as well. So you'll see intervals of P waves, and you'll see a different interval for the QRS segments.
This is a great illustration of why we have different pacemakers at different parts of the heart. When we think about the functional normal heart, the SA node will always win because it's got the higher frequency. So that's going to be the rate that our heart goes at. But when we have this third degree block where we have effectively severed communication between our atria and our ventricle, they have their own pacemakers that are telling them to do their own thing, which when we think about it from a perspective of cardiac output, that leads to a lot of problems. So that's some pretty straightforward pathophysiology of the heart. Let's move on to what we can do about it. When it comes to bradyarrhythmias, the medication list is actually quite short, as is the intervention list. But we'll take it step by step. The bottom line that I want everyone to think about when it comes to bradyarrhythmias is that it's the unstable patients that need intervention, right? What defines unstable in a bradycardic patient?
The top 2 things that come to my mind are hypotensive or poor perfusion in the patient. Other things can include an altered mental status or trouble breathing, but those first 2 are the key indicators of we are not hemodynamically stable.
What does poor perfusion look like for us on a pre-hospital basis? Like, what kind of things can we do to assess if they're hypoperfusing?
A simple one is checking to see the color of our skin or the capillary refill to see if we can get that blood throughout our entire body.
Cap refill is a very good one. The other way I think about it is end organ flow, right? When we think about altered mental status in a patient that's hypotensive, that's because there's poor blood flow to the brain. Sometimes we talk about urinary output, but that doesn't really matter so much from a pre-hospital setting. Though I would say that if family members note that their urinary output has decreased, or if let's say they have a Foley catheter in place chronically, you can still use those benchmarks to give you additional input into how perfusion is going overall. Let's move on to some of the medications that we would have in our arsenal in the case of bradycardia. So, Regan, if we had a patient that absolutely needed medication intervention, what's our first line medication of choice?
Our first line medication in symptomatic bradycardic patients is atropine.
Atropine. It's our friend. We love it. Whenever there's a bradycardic patient, we slam it in. But we talked about using our brain here, right? So what is the class, first of all, when we think about atropine, and then how does it work when it comes to the anatomy and physiology we talked about so far?
So atropine is called an anticholinergic medication. And when we hear that cholinergic, we're thinking parasympathetic, so that relaxed system in our nervous system. When we hear anticholinergic, that just means we're going to be blocking that parasympathetic. And this happens through blocking the vagus nerve, which can slow our heart rate. By blocking that, we're bringing that heart rate back up, again, just undoing what the bradycardia is doing.
We also call this a vagolytic action, which I always think is a fun word, vagolytic. Remember that the vagus nerve is the chill out nerve. So we need to basically shut off the signal from that nerve in order to get that heart rate back up. There are certain situations where the vagus nerve is not playing a role anymore and our medication becomes ineffective. What are some of the classic scenarios in which atropine may be ineffective?
Well, one that we might see up north is hypothermia. Other things could be if there's a heart transplant or more advanced blocks.
Yeah, I think the big one that you really need to be aware of is if your patient is a heart transplant patient, that vagus nerve is gone. They can't reconnect that in a transplant scenario, so atropine will no longer work for this patient. Let's say if that atropine doesn't work, what's the next option that we can move forward with, Regan?
So our second line treatment is epinephrine.
Oh, epi. We've talked about this already, but we're going to rehash it again. So let's talk a little bit about the class and mechanism of action, just in case some of our listeners haven't listened to our first episode of anaphylaxis, which is a great episode, and you should all go listen to it.
So, a little review from that episode is that epinephrine is an alpha and beta agonist. So, by doing the same action as the alpha 1 receptors in our body, that causes vasoconstriction of major vessels. The beta 1 agonist will increase the cardiac output and have actually a positive chronotropic effect on the SA node, which just means increase the heart rate. And then the beta 2 agonist part causes vasodilation of the coronary arteries. So that's a whole lot of physiology being affected in these scenarios, with the whole point of increasing some blood return to the heart and to the heart's tissues.
This is why I think talking about the pathophysiology and just understanding the circuitry is so important. Epinephrine is a great drug in this situation, right? So we talk about, we've got the vasoconstriction of major vessels so we can address the hypotension. We've got increased cardiac output, which we need because there's poor perfusion going on. But then here's this counterintuitive step with the beta 2 agonist, right? We talk about vasodilating the coronary arteries. And Regan, you kind of hit on it a little bit, but by dilating those vessels, we get more blood flow in, we get more oxygen to the heart. So effectively, we're trying to get rid of that irritability and trying to get us back to that normal rate that we're looking for. So those are the big two medications. If you look at the AHA guidelines, they talk about dopamine. And my paramedics who know me very well and my EMTs that know me very well, I hate dopamine. It's a terrible drug, and I got it beaten into my head when I was a resident that I am never to give this medication in the context of bradycardia. Regan, do you have any idea as to why dopamine is a terrible drug and why I will never give it?
I don't. I think I've just accepted that it's a terrible drug because doc says so.
I like that. That's a good answer, but let's try to think about it a little bit too. So dopamine back in its heyday was one of the medications that cardiologists really liked, and it's a great drug in terms of getting your heart rate up, getting your blood pressure up. But one of the downsides of giving dopamine is that it's also very arrhythmogenic. So sometimes we get some downstream effects or some rhythms that we don't want to see. I actually saw this once as a second year resident. It was actually my first day, I think. And it was a patient who came in that was floridly septic, hypotensive, and they wound up giving this patient dopamine and they watched as this patient went into AFib with RVR. So then first of all, I had to reverse this AFib with RVR before I could start even getting to the sepsis part of things. For me, that was kind of my life lesson of why dopamine is not a great drug. And quite frankly, since epinephrine is such a great first line drug, I don't think we should even be having this conversation anymore. So we talked about the two medications that I really prefer to use in the context of bradycardia, but what happens if those two medications don't work and we still have a hypotensive patient?
If our medications aren't doing the trick, our next step is actually to go to cardiac pacing. And when we're in the field, this is typically done with transcutaneous pacing with the defibrillator pads.
Yeah, so transcutaneous pacing is going to be the only other thing that we can do from a pre-hospital setting. When we think about transcutaneous pacing, though, it's still a bit of a long shot when we think about it, because depending on the patient and their size, there's a lot of tissue for that electricity to go through. So how does that work in terms of getting it set up for transcutaneous pacing?
So with that one, they will be hooked up to the monitor, and they already should be since we've been assessing them this entire time. But we'll actually add on the pads in place where you typically put them for resuscitation measures. And within the monitor, there is a pacing setting that we can program into it, and it will actually shock the patient through the pads at the rate that we set it.
And that's the key word here that I want to focus on. We are shocking a patient who is awake. So when we think about this process, we're basically putting electricity through the patient's skin into their muscles and trying to get it down to the pericardium and to the heart itself so we can get that rate capture. But what's the big downside of electricity going through a patient's body?
Well, first and foremost, it's an incredibly painful experience for the patient because you're not only shocking the muscles of the heart, but you're shocking the muscles in general.
Right. So every time that shock comes, they're getting a huge spasm through their chest too. I had one patient describe it as feeling like they were getting kicked in the chest by a horse repeatedly. So we definitely need to think about some degree of anxiolysis if we're going to be a long transport. So this is where we talk about things like Versed or ketamine, but we can certainly talk about anxiolysis and procedural sedation at a later date. One last thing I want to touch on when it comes to interventions, because sometimes this may happen and we may transport a patient, is something called transvenous pacing. This will probably not happen where I practice, but I have requested that my hospital does have a transvenous pacemaker available in the event that we have a blizzard or something that's going to prevent us from getting the patient from point A to point B. And so this is something that's very unique to a rural setting, but I do want the paramedics and EMTs out there to kind of understand what the thought process might be. The transvenous pacemaker is very similar to our transcutaneous pacemaker, with the exception that we are basically getting a pacemaker right to the heart of the matter, no pun intended. This is one of the coolest procedures I've ever seen. I have not had the privilege of doing it yet myself, but I did watch one of my senior residents get to do it twice in about 3 months. How this works is that we start by getting a central line placed in the right IJ. And once we have that central line set up, we have a little apparatus that we can put together and effectively float a pacer down into the right ventricle. And how this works is that as we slowly advance this pacemaker, we watch the rhythm on the monitor and we wait to see capture. So it's very similar to what they do from a transcutaneous perspective. This is something that we can do that gives us a higher chance of capture, because one of the shortcomings of transcutaneous pacemaking is that sometimes we just can't get that capture. And sometimes this is just due to a patient's body habitus. Sometimes it's related to the pathophysiology itself that just makes it less responsive to transcutaneous pacing. But this is one last line of defense that we can do potentially to keep the patient's heart rate at a much more safer range. So we've covered the pathophysiology of bradycardia. We've covered the medications. We've covered some interventions. Maybe it's time to talk a little bit about evidence-based medicine, Regan.
Let's hear it. What do we have today?
So I did a little digging. We had talked a little bit about glucagon during our last episode. For those of you that have not listened to that one, I highly recommend it. And there might be just a little bit of retconning going on, because I did leave a few things out that I wanted to circle back and discuss. One thing I wanted to bring up was that in the event that we're going to give glucagon, this is highly emetic. When we give high doses of glucagon, people can get nauseous. So you really need to warn your patients in advance that this may make you nauseous and you may throw up. So being able to pre-treat our patients is super important in the context of glucagon. Now, with that being said, I want to talk a little bit about the more unique situations of bradycardia. Last time we talked on the podcast, we did talk briefly about medication-induced bradycardias and how we might be able to overcome that. The classic answer in the past was talking about high-dose glucagon. That being said, there's been some discussions recently about introducing high-dose insulin, and there's been a lot of studies done in relation to that. When we talked about this last time, basically what we've discussed was that glucagon allows us to help bypass something that might already be blockaded, which is going to allow us to get some increased vascular resistance, get some increased inotropy, as well as some chronotropy in these patients that have beta blockade in place. Going into the weeds a little bit more, I didn't really give a real mechanism for this, but basically what glucagon does is it helps increase something that we learned in med school and then we immediately forgot, something called 3,5-cyclic adenosine monophosphate. But basically, this is one of those molecules the body uses for energy and then allows it to perform a whole host of functions. Now, when we think about glucagon versus insulin, this is where things can get quite interesting. The mechanism of action for insulin is complicated. I'm not going to go into it just because there's a bajillion things it does, but the list that we're most interested in when it comes to the bradycardic patient is that when we give high-dose insulin, it can give us increased inotropy, it gives us increased intracellular glucose transport, and it also provides some vascular dilatation. So going through this step by step in the context of bradycardia, high-dose insulin gives us increased inotropy. And the evidence out there suggests that this is probably a multifactorial effect, but it's from the high-dose insulin that leads to the heart contracting stronger and harder. The other phase of this, when we think about cellular transport, is that the heart loves energy. And so we need to get the heart more energy so it can get more function. So by giving the patient high-dose insulin, we wind up getting an increased amount of intracellular glucose, which then is transported to both our cardiac cells as well as our skeletal muscles. When we think about it from the vascular perspective, this involves the systemic vasculature as well as our cardiac and pulmonary vasculature. But in the context of our discussions, it's believed that by having this vasculature impact in the cardiac cells or the cardiac vasculature, it actually vasodilates. So the bottom line here is that when we give glucagon, we do expect to see some increased inotropy, bronchodilation, and vasoconstriction. That's the generalized idea for glucagon. When we think about the insulin mechanism of action, it's actually quite similar. Insulin is a very complex molecule, and there's a lot of mechanisms of action as it does have a variety of uses in the body itself. However, since we're talking about the heart today, I want to focus on three main features. What we can see is increased inotropy, we can see increased intracellular glucose, and we can see increased vascular dilatation. So when we think about it from a transport issue, the heart loves energy, and sugar is one of the best sources of energy in our body. So by increasing our intracellular glucose transport, we get more blood sugar to the cardiac muscles, which can then help support continuing higher heart rate and giving better contractions, which kind of goes into this idea of increased inotropy. So the inotropy is increased somewhat from glucose, but with the increased biochemistry research does seem to demonstrate that this is a multifactorial downstream effect. So there's probably a lot more going on than we currently know in regards to the heart pumping stronger and faster. Lastly, when we talk about the vasculature of the heart, we kind of mentioned earlier that coronary artery dilatation is kind of helpful because it increased blood flow, we get increased oxygen, and then we get increased glucose. So we can see where then insulin could play a very big role here. We do know that insulin does provide changes to the vascular system, but specifically when we think about the cardiac component, we know that there's going to be increased flow to the myocardium, and it's going to bring us a lot more sugar, a lot more oxygen, and everything else it needs to function better. On paper, they sound like they do the exact same thing. Do you think that they are equivalent, though, when it comes to being administered?
It really does sound like that.
And they've done studies on this. So I'm only going to talk about two because there's a lot of stuff out there. These both come from the same journal, but the first one is from Clinical Toxicology in 2011, and that was discussing this whole idea of high-dose insulin therapy and beta blockade, as well as calcium channel blockade. So we're talking about in the context of a patient that has accidentally or intentionally taken too much of their beta blocker or their calcium channel blocker. So what this study looked at specifically was if we gave a patient high-dose insulin, would we expect better outcomes? When they first looked at this stuff, this was from a animal model perspective. So when we think about studies in the past, they were basically looking at high-dose insulin in contrast to calcium salts, glucagon, epinephrine, vasopressin. So basically everything we throw at the body already, trying to keep that blood flow going, keeping that blood pressure up. And what they did seem to see was that high-dose insulin did seem to increase the frequency of good outcomes in the animal models. And so that's what led to this suggestion back in the early 2000s. What this particular facility did, which is actually out of Minnesota, so shout out to our Minnesota people, the high-dose insulin protocol that they used was they initiated a 0.5 unit per kilo bolus, followed by a 0.5 to 1 unit per kilogram per hour continuous infusion. What are some possible downstream effects that we think about, Regan, when we initiate high-dose insulin? What kind of consequences would we expect to see?
Well, we could expect to see a drop in that blood sugar, which we know happens when people give themselves too much insulin.
Right. So one of the problems we'll have to address is how do we keep the blood sugar up while continuing to give this high-dose insulin? What's another possible complication we have to think about?
We'd also be thinking about potassium.
Exactly. So hypokalemia comes into play here as well. And we both know that low potassium can also lead to problems, just like high potassium can lead to problems. So there are still some downstream effects that could potentially lead to more problems. So that's one study that talked about the idea of high-dose insulin, but how does that look from a bigger picture? I did pull out one other study. This article is from 2020, and it also comes from the Clinical Journal of Toxicology. This is what we call a systematic review. Regan, you love stats. You love that class, I'm sure, just as much as I did. What is a systematic review, and what makes it a powerful resource?
So the systematic reviews are kind of the top notch of research because they're using a bunch of other research projects and analysis and bringing it all together, comparing all of those results to come up with a cohesive, this is what we know.
So basically, the whole purpose of this is just like you said, we're trying to get the best of the best literature out there and putting it together to see if we can give you some definitive answers. This also is very important because when we think about doing studies in humans, it can sometimes get unethical to withhold certain medications from patients. So the more data we can collect, the better the study we might have. One of the limitations of systematic reviews is that you've got to take good journal articles, and that's where a good peer review process comes into play. So the name of this article is called Treatment for Beta Blocker Poisoning, a Systematic Review. So basically what this group of researchers did is that they went and they searched through the databases that they had, going back for, looks like as far back as like 1974. What they did was found 141 journal articles that were highly powered. And when we think about highly powered articles, it's basically saying that this data is saying what it's supposed to mean. So from those 141 articles, they basically sat there and broke down all the interventions that we have out there right now and which ones seem to have the best outcomes versus which ones are a little less reliable. In terms of like the bottom line, What they found that worked the best were things like catecholamine and vasopressors, which doesn't surprise us. Things like epinephrine, Levophed, things that can help both increase our heart rate as well as address blood pressure. But one other thing that they mentioned in their list of things that seems to be highly effective is high-dose insulin. So high-dose insulin therapy seems to be a reliable source when it comes to trying to address this beta blockade and sometimes calcium channel blockade. So looking at this a little bit closer, they also did discuss glucagon. What they found is that glucagon did seem to be associated with minor improvements in hemodynamics through an increased heart rate in 2 case series, 9 case reports, and 5 animal studies. So there was like some data there, but when we compare it to the high-dose insulin therapy, they found that the mortality benefits were a lot higher. In about 10 case series, it also showed that there was clear hemodynamic improvement in a time frame consistent with insulin administration. So the other thing to take away from this is that if you're going to do high-dose insulin, you want to do it early. There was some discussion in this paper about that sometimes if the high-dose insulin therapy wasn't started in a quick enough fashion, the effects were not as obvious. Bottom line that I want you to take away from this is that there are some things out there that do suggest that glucagon and insulin probably do play a role. But when it comes to which one is more effective, it's actually going to be the high-dose insulin therapy. So if we've got patients that were concerned about beta blockade or calcium channel blockade, maybe doing a high-dose insulin therapy in the future might be a good idea. It might be something worth talking about in protocols in the future. They also talked about ECMO, but I don't think we're doing ECMO in the middle of nowhere.
Just throws in ECMO. Simple.
So that was a little bit of a heavier evidence-based medicine this time around, but I thought it would be some good practice for our EMTs and paramedics out there to think a little bit about how do we pick good studies and what are some examples of some highly reliable journal articles. The bottom line is I want you to take away that systematic reviews are great under the context that you're picking articles that do actually answer your questions. So we've talked about pathophysiology, we've talked about the meds, we've talked about a little bit of evidence-based medicine and the interventions. I think that just leaves us with the protocols themselves. And once again, Regan has put together our protocol expertly, and we will now walk through that a little bit step by step, and then we'll wrap this sucker up.
So our protocol for bradycardia is going to follow similarly with our other ones. We are always starting with that initial assessment and hopefully getting them onto the monitor to see a better clinical picture of what's going on. Because most of the time, we might not know what protocol we're going through until we have the picture that our patient is trying to show us. So within our protocol, first and foremost, we'll get a 12-lead EKG as well as get an IV placed. Another thing that I have early on in there is to take a blood glucose. And we mentioned this when we were going through the case initially. Because we might not know what's going on, we need to acquire as much information as we can. So as they're hooked up to the monitor, we can begin that read if our medic is with us. Once they're reading that strip, we have our partner also assessing that hemodynamic stability. So are they hypotensive? Is there signs of shock? Do they have that altered mental status? All of these things that are going through our head during the first part of our protocol. Once we figure out what's happening and we're into that, this is a bradycardic patient, we'll move on to those meds, which we have, of course, that first line med of atropine, and then we move on to our pressors, which is our epinephrine. The transcutaneous pacing may or may not occur if those meds are successful, but it is in our protocol, and we will additionally make a sedation protocol to help us out with that transcutaneous pacing, but that's a topic for another day. Also in the protocol, we have the scenario for a pediatric bradycardic patient, and I wanted to point out the most important part here is that if we have an infant, so a really young pediatric patient, and that heart rate is 60 or less, it's no longer treating it like it's bradycardia, we're treating it like it's arrest. And I have the American Heart Association algorithms within this protocol for that exact reason. We want to make sure that we're properly assessing the pediatric patients, because if that heart rate is so low, we will actually start CPR as opposed to doing epinephrine and atropine. So of course, as it goes within our protocol, we have it all written out for those that like to read, and we have some algorithms in place, of course, ignoring the dopamine that's in there for our visual learners.
Yes. Dopamine is bad. Put a big X on it, scratch it out, rip it off the sheet. I don't care what you do with it, just get rid of it. So bottom line for the bradycardic protocols is assess your patient, check that blood sugar, get your EKG. Remember the types of bradycardia out there. So things we think about in this case would be sinus bradycardia, your second degree AV block, your Mobitz 1, your second degree AV block type 2, or your third degree AV blocks. like we talked about during the evidence-based medicine component, if we're concerned about beta blockade or calcium channel blockade, then we think about either doing some glucagon IM or IV, but remember that it is highly emetic, so make sure that you're giving them an antiemetic accordingly. Or if we expect a longer-term transport, potentially something like high-dose insulin may be something worth considering, but that might be a discussion at a later date to see if that's something we would want to proceed with in our protocols. So I think we've covered our protocols at this point. Let's get back to the case in question. Your patient is bradycardic. You've got evidence for hypoperfusion, Regan. What else do you want to know before you start treating?
I would want to know what medications they're on. Is this a beta blocker overdose so that we can consider those other treatments in hand?
So when you ask about other medications, the wife does go and get his bottles of medications, and you find out that he had been having some really bad headaches recently, and his provider had told him that if he was having really bad headaches, it was probably due to his uncontrolled blood pressure and he should take some more of his medications. You also learn that he's got a little bit of dementia and he may have inadvertently taken one too many of his beta blockers.
So definitely things of note for both my treatment and what I want to relay to our ER docs when we get there. But knowing that we have that hypotension, hypoperfusion, and things might start going downhill, we have that goal of getting that heart rate back up.
And looking at your monitor, you do see what appears to be a sinus bradycardia. You don't see any evidence of blocks. It's just going very, very slow.
So this is where my hand's going to be reaching for some atropine. And I know I mentioned with the sinus bradycardia, if there's no symptoms, you don't need to jump to that. But clearly we're having symptoms in this case. So my next step would be to push that 1 milligram IV atropine and see where my vital signs go.
So you push the atropine, you get the guy loaded up into your rig and start going. And you do notice that you do get a temporary increase in heart rate. I would say maybe up into the 60s and 70s for a little bit. And then it starts to slowly sneak its way back down again.
And that was a really important point you made too, is that once we're starting these medications, we're going to get transport going as well. Because while we can help fix things in the field, we want to get to that definitive treatment. So seeing that our heart rate went up, so we were having a response to our atropine, meaning that it's probably not a heart transplant patient. Our vagus nerve is still intact, so we can cause effects to it. If our heart rate's starting to decrease again, we can push another round of atropine, and you can do up to a max dose of 3 milligrams. So we have a little wiggle room right now. I'd probably press it again.
Right. So you can give another milligram every 3 to 5 minutes until either you get resolution or you reach your 3 milligrams. So you do that, you get another response again. Like last time, it slowly starts to creep back down, and you're still probably about 20 minutes out from getting to your receiving ER.
So if we still have time and we're up to that max dose of that atropine, we move on to our second med, which is that epinephrine. We can actually have this in a form of an IV drip, which should help us to last until we get into that ER.
So you set up your epinephrine IV drip and you look up at your monitor and notice that as the medication gets titrated up, you see some response with your blood pressure as well as with your heart rate, but just not quite getting the effect that you would expect in the traditional symptomatic bradycardia scenario. So what worries you the most about this, Regan?
This would definitely hold true if we are having that beta blocker toxicity. So I would want to move on to our next thing, which would be that transcutaneous pacing. And I think the really important point that I actually missed earlier is that I would want to have those cardiac pads in place probably around the time that I'm starting that atropine, just in case the situation changes or we're now at that time of transcutaneous pacing. We're not having to delay, put a little pause in our treatment as we get everything else set up.
Sounds good to me. Anything else you want to do for this individual?
If we're doing this pacing, we definitely want some sort of pain control or sedation. So this is where we could be doing that ketamine or Versed. Like we talked about, it will be in a future protocol, but a little sneak peek there.
Anything else you could potentially give this guy while you're going, trying to help reverse that process?
If we are thinking that this is a beta blocker overdose, we can get that glucagon on board, IV.
Right. So you can either give the glucagon IM or you can give it IV in these cases. And you find that once you do that, not only do you see a slight improvement, but you also notice that the epinephrine seems to be working more, and you can start to titrate the epinephrine down. So thankfully, you could even turn off the pacers in this case just because of that use. This is actually a real life case that I had when I was on my EMS rotation as a resident, and it was a gentleman that had inadvertently overdosed on his beta blockers to the point that he had excessive beta blockade. He had sinus bradycardia, line was in, but the medications given IV were not being effective. As I was was heading out the door with my paramedic team, my mentor, who was the EMS director of the program, reminded me that it might be worth a shot to give this gentleman some IM glucagon. And so that's exactly what we did. While we were getting this guy lights and sirens to the nearest ER, we wound up giving him an IM dose of glucagon, and it was really quite interesting to watch that heart rate gradually improve and actually start to respond to the IV medications. I definitely do acknowledge that glucagon is certainly an option, but given the data, I really do wonder about doing high dose insulin in the future. And just like that, I think we've just completed another episode of Medics, Musings, and Mayhem. Now that we've knocked out bradycardia, though, Regan, I'm a little bit apprehensive about what sort of tachyarrhythmias they're going to want us to cover first.
It might get a little extensive. And we also need to do all the rest of the things cardio. So it's going to be a long little sequence here.
Yeah, I agree. So we might need to break up the monotony a little bit here and there, because I'm sure some people will get very sick of things cardiac. So we'll have to look and see if there's any other shorter topics that we might be able to do for a brief reprieve from all things cardiac. We've got a lot of choices ahead of us. We've got all the tachyarrhythmias. We've got heart failure. We've got cardiac arrest. I mean, the world is really our oyster at this point. I have already polled the people and they have spoken. They have requested that we start with all things tachyarrhythmia. And full disclosure, I think the best course of action going forward is that we are going to definitely split these up into subgroups, since this podcast today alone almost ran 45 minutes or so. So we'll definitely meet everyone's needs about getting tachyarrhythmias covered, but I do ask that you be patient, as this will likely be a 3 to 4 parter based on what tachyarrhythmias we cover next. We will try to get a website of some kind set up in the future so that you can access our show notes as well as the diagrams that Regan has expertly put together. Until then, we'll catch you next time, and we will have a whole host of cardiac adventures for you to go through. And may your mayhem be well controlled, full of teachable opportunities, but also provide you with the opportunity to provide your patients with the best care possible.